Good afternoon, everyone, and welcome. My name is Katie Naples Mitchell. I'm the program director here at the Program in Criminal Justice Policy and Management at the Harvard Kennedy School. And on behalf of our faculty director, Sandra Susan Smith, who's also logged on, although she is on sabbatical, I'm really delighted to welcome you to the kickoff event for our fall speaker series. This has been a labor of love and big production effort by our guest moderator for the series, Dr. Kara Buchanan, who is also a student here at the Kennedy School, and I'm going to give you a fuller bio for Kara in just a moment. But I wanted to begin just to give some kind of ground rules for how we run this series and meetings, and let folks know that the event is being recorded. So if you don't want to be participating in a recorded event, please take heed and do what you see to mitigate that as you see fit. We will post the recording of the video on our YouTube channel. I will drop a link in the chat to that so people can follow along and also catch up on other past events on different topics if you're interested. We have 6 of these events over the course of the semester. They are staggered, not quite every other week. Our next event is the following week, September 25th. But then after that, we have a little bit of a break, and our third event is October 9th. So you all should have been registered for the entire series by registering before today. And there should have been a way to add that to your calendar. So anytime that they come up in the kind of alternative cadence, they will show up on that calendar invite. We try to keep this as an open meeting rather than a webinar so that people can engage and see who else is on the call and make connections virtually in this shared space. So with that in mind, please be mindful of making sure you're muted during the call unless you are asking a question of our panelists at that point in the event. And my colleague Brian, who is also here and does a lot of the back-end logistics for us, who is so critical to everything we do at the PCJ, will also help make sure we're all muted when we shouldn't be talking. Finally, we try to have these events be engaging, and so we encourage you to share resources in the chat. We encourage you to ask questions as they come to you, and I will be helping support Kara to go through the list of questions in the order in which they're kind of registered when we get to the sort of question and answer portion of the event. So feel free to engage and ask those questions, and then our panelists can ask them at the end. And we do ask if folks want to unmute and ask your own question. So you can kind of preserve your place in the queue by typing that into the queue, and then you can unmute and ask your question when the time comes. With that said, I think that's all of the kind of upfront administrative logistics. And so I will now introduce Kara more fully. Kara Munoz Buchanan is a practicing emergency physician and clinical fellow in health policy and social emergency medicine research here at Harvard. Her focus is on the health and human rights of detained and incarcerated patient populations, and her research seeks to evaluate clinical experience working with justice-involved patients and translate it into clinically informed health policy innovation at the local and national levels. She is currently completing her master's degree in public administration here at the Kennedy School, as I mentioned, where she's exploring these connections between emergency clinical practice and larger systems and structures of detention and incarceration in the criminal system more broadly. So I will now cede the floor to Kara, who can introduce our phenomenal panelists in this first event. And again, thank you all for being here.
Thank you, Katie. All right. So thank you all for being here and for all of the wonderful feedback we've received so far. Please feel free to reach out to us at any time. I'll include my email at the end if you have any feedback, questions, concerns, or want to highlight anything in particular. So just a huge thank you again, as Katie mentioned, to the Harvard Kennedy School's Malcolm Weiner Center for Social Policies program in Criminal Justice Policy and Management, and particularly to our faculty director, Sandra Susan Smith, our program director, Katie Naples Mitchell, and Brian Welch, who has been our program administrator throughout the series. So thank you all again. So I just want to get started with kind of the origins of the series. So this started back at the Harvard Radcliffe Institute in June, where we had the opportunity to kind of amass a few experts in the field across the country, ranging from the realms of policy, advocacy, education, and research, to kind of convene around a central question of what are the 5 biggest problems that we need to solve to address inequity in healthcare provided to justice-involved patients. As we know, this space definitely involves a very multidisciplinary team of both policy, clinical practitioners, anything from the actual correctional staff and management to the like state, federal, and local regulations and jurisdictions that are involved. So this is a big question. We tried to kind of break it down into different groups, and I'd just like to share kind of what we came up with, because it's something that we're going to be weighing in on throughout the course of the series to kind of figure out if there is some consensus around areas to move forward and highlight. So the first one we discussed was about narrative and issue framing. Really, how do we speak about justice-involved patients? The historical lens that informs who's in this space generationally, racially, linguistically, ethnically, geographically. How are these voices shared in the larger community to add the human element of reality of what people are experiencing? And really how we can help shape that conversation on a larger scale for those who have been touched by justice involvement and those who have not. The second area that we highlighted was kind of defining this idea of standards of care, which in the medical field is kind of how we practice as our gold standard. What are the community standards of care? What are the professional standards of care? What are the clinical standards of care? And do those exist in this space or not? The third area that we highlighted was privatization and financing. Obviously, some large regulation that goes into this space that I'm going to get a chance to ask a lot of our experts about. Challenges to implementing alternatives to incarceration, although this terminology has become a little bit more baked into some newer policy reforms and waivers, there still are some very, very large and sizable challenges to kind of pursuing alternatives to incarceration. And finally, this issue of transparency, oversight, and accountability in the space, and the inclusivity of quality data metrics to help kind of look back on what we're doing and remain accountable to some standards that we may be able to come up with, and how or how not there are systems that kind of address oversight and accountability. So the space that we've created here is a really unique one. I think we're going to have the chance to hear from policy and clinical practitioners who work on the micro and macro level. This space can feel very siloed at times, and I think that this is going to be a wonderful place to kind of create a community. Please be active in the chat, and please feel free to reach out to us to kind of maintain connection throughout the series, and thinking forward to how we can maintain connection as a community, really working in this space to solve some issues that don't quite have solutions yet. Lastly, I know this is a very deeply personal space for a lot of people with lived experiences of our own and those that are close to us, those of the stories of patients or people affected by the carceral system in the United States. So as the moderator, I am here to spark curiosity, allow opportunities to kind of imagine connections between our work. This is by no means a comprehensive or perfect representation of the issues, but I really hope this is a space that we can kind of continue to build from here. As Katie mentioned, my interest kind of lies at this intersection of justice policy and emergency medicine. This is my email. If at any point during this time you'd like to reach out and kind of make a connection about an issue that you'd like us to highlight throughout the series. So what really informs, I think, bringing these three speakers today together to really target this first part of the series of what is the nature and extent of this space. Think back to Long Walk to Freedom, where Nelson Mandela writes, "It is said that no one truly knows a nation until one has been inside its jails. A nation should not be judged by how it treats its highest citizen, but its lowest ones." And I think that for those of us with experience in this space, it is very challenging sometimes to know how to relate what we see, hear, and experience to people who haven't been touched by the system. And it's our effort to kind of try to make that an important and meaningful connection for everyone across the country and internationally. So without further ado, I'd like to go through our three speakers for today and kind of get kicked off with some questions for our first speaker is Emily Widra. So Emily is a senior research analyst at the nonprofit Prison Policy Initiative, which I'm sure many of you have seen beautiful graphics and information come out of. And she is tasked with overseeing health and mass incarceration. This has included COVID-19 data, medication-assisted treatment, and topics related to HIV in prisons and jails. Emily is someone who combines policy and practice in real time, and really gives us this wealth of data through her work with PPI, and also is a licensed clinical social worker with extensive healthcare experience since completing her social work degree at Smith College. So we're really lucky to have Emily with us today. Leo Beletsky. Professor Beletsky is a professor of law and health sciences at Northeastern University and the director for the Action Law at the Center for Health Policy and Law. The Action Center at the Center for Health Policy and Law. Professor Beletsky is an expert in the framing of public health impacts of law and enforcement with a focus on policing as a structural determinant of health. He also focuses on substance use disorder, infectious disease, and the occupational safety of first responders. And Katie McCready is a PhD student and research lead at Northeastern University in Population Health Sciences program with a focus on epidemiology and biostatistics. She leads some qualitative and quantitative data projects with Professor Beletsky, and her work is focused on translation of data into advocacy tools. So she'll be sharing some of her work related to the Carceral Research Index with us later today. So just to kind of get us started, we'll be sharing some graphics throughout to kind of represent your respective work, but I wanted to kind of come back to these 5 areas that we've identified and just briefly touch on your initial reactions to, do these 5 areas resonate with what you found in your work so far, and which might be more pressing or potentially ones that you disagree with?
Sure, I can go. Thank you for introducing me and everybody. So yeah, I think that just thinking about this first one about narrative and issue framing, I think that this really stands out to me because part of the work, and we come from sort of like a data analysis, data visualization perspective at PPI. This can be really challenging just in that the narrative and the issue framing of sort of the carceral system is behind this, curtain. And all the work that we do is to try to like peek behind the curtain and see what information we can get. But the current narrative or sort of the pervasive narrative is that it's something, that's behind this curtain. We put people away and they go away, where the reality is that they're still part of this community, whether they're incarcerated in a jail or prison or on probation or parole. So thinking about how to shift the narrative away from like an us, them, or like this distinct separation, I think is pretty crucial and something that started to happen a little bit during COVID, like when we think about community transmission of COVID itself, like, and how that was like going back and forth across prison walls. But I think it's something that really stands out to me as crucial to this work.
Yeah, just to build on that, and thanks, Karen, Katie, and Brian for organizing this. This is such an important topic and a timely conversation. I think that I'm actually a huge fan of the Prison Policy Initiative and fangirling over here a little bit. But I think that there are a lot of myths and a lot of misconceptions about what the system, the criminal justice or the criminal legal system is and how extensive it is. I think a lot of times folks talk about it without having a good grasp of the nuances, starting with things like, difference between prisons and jails, for example, the fact that jails are, the primary place where folks are incarcerated, and most of the time they're pre-trial, they haven't even committed a crime. And then prisons are places where people are serving their sentences. The fact that the vast majority of folks who are under the control of the criminal justice system are not actually behind bars. They're out on probation, parole, community supervision. The fact that there are different forms of incarceration. Sometimes it's physical and sometimes it may be virtual. A lot of folks have to wear electronic monitoring equipment. They have lots and lots of conditions that govern their lives, including where they can live, who they can talk to, what substances they can use. So the scope of control of our criminal legal system is far, far broader than just the folks who are behind bars at any given point in time. And it's the world's, US is the world's largest jailer in population rate terms and in absolute terms sometimes as well, meaning that we put many more people under criminal justice control than just about anyone in the world, and certainly our peer nation. So why that is a complicated question, but I think the bottom line is that the criminal justice system plays an outsized role in American society, and that role is also not evenly distributed. That some folks are much more frequently coming into contact with the system, and the system has a much more outsized role in their lives of some folks versus others. So thinking about the narrative and issue framing, I think, is really important. But it's also important in terms of the specific question about provision of healthcare behind bars, because people are coming in and out of the system all the time. And so folks who are behind bars are also members of our communities. And so the idea that there's like some kind of firewall is really does not reflect reality.
May I say something? I'm Sharon.
So
And
Hi,
I
Sharon,
wanted-
Sharon. So
Oh, sorry.
sorry. We're gonna wait and have an opportunity for full Q&A at the end, but we want to give the panelists a little bit of time to talk first, okay?
thank you. So just to kind of launch us in, these are the two kind of areas that we're going to dive into, how we, different organizations have helped to try to capture this scope, nuance, and depth, really, and breadth of what these issues seek to address. So kind of as a reference, the Prison Policy Initiative has really tried to tackle this issue of, what is the overall scope? And this is a very, kind of famous image that is released every year by PPI. And Emily, I was just hoping you could speak a little bit to this, very memorable graphic about how this helps understand the components of the system, and then how we start moving into the healthcare components of the system.
Yeah, absolutely. I think not to belabor how many, slices of the pie there are, but I do think that that's one of the things that this graphic shows that has pretty serious implications for the provision of healthcare to people who are interacting with the criminal legal system. So there's all these different actors in this system, right? We have sort of the state and state prisons. Those tend to be people who are convicted in state court. Then we also have local jails, which Leo already touched on as being a place where people are traditionally held without conviction, usually pre-trial. But there are some that are convicted and serving generally short sentences. Then we talk about the federal system, and then youth and immigration detention and involuntary commitment. And all of these slices of this pie of the carceral system are run differently and are run by different actors. And so that really complicates, I think, when we talk about this like monolith of the criminal legal system, of how to impact change and how to make change happen in these spaces. There's so many different, bodies of control, I guess. And so how to think about healthcare in each of these settings is going to be different, especially if we think sort of the traditional dichotomy of jails versus prisons. Jails tend to be people usually only in there for a few days to weeks. People cycle in and out of jails. State prisons, people tend to stay longer. Of course, there's exceptions to that. But when we talk about healthcare, I mean, those have pretty serious and different impacts on health. If you're in a jail for 3 days out of your week, and then you return home, you may have missed your appointments, you may have lost your job, you may have missed your medication-assisted treatment. All kinds of complications can arise from that. Whereas the state prison, when you're there, it's responsible for your health care. And so that also comes with negative consequences as well. So yeah, I think that sort of thinking about this whole spectrum of the criminal legal system can feel a little overwhelming, but breaking it down into these slices has meaning both for understanding it, but also impacting change.
Yeah, absolutely. And I think you'll hear a little of the vocabulary that, we will all happily share in the chat as well some of the descriptors that we, this field is always shifting and adjusting to different terminology, but the criminal legal system is kind of the term that we're going to try to stick with. As mentioned, criminal justice system, a lot of times the kind of false pretense of justice a lot of times feels elusive in this space. So that's why you'll kind of hear different vocabulary. But thank you for kind of explaining this I think this really sets the scene for kind of where we enter with healthcare. The other really critical component for how we even start to like digest this is this next graph. And we would be remiss without discussing, the most important disparity to kind of highlight right away, which is the Black incarceration rate compared to whites. And the Prison Policy Initiative has run a lot of data on this. Katie, I was also interested as you guys started to work on how you started indexing kind of different social services and layers to this. How did you guys start thinking about, health disparities related to obviously very, very prominent racial disparities, not all of which are represented here on this graph, but certainly this is the most striking one to kind of talk about initially.
Absolutely. And thank you for bringing up that really important point. I think one of the beauties of how we use CRI is that things like the census of local government finances, their budget categories are really broad. And so it's difficult to kind of get into the nuances of spending prioritization to, specific programs or, specific organizations, especially as it relates to the carceral system. And so actually getting to look at the Carceral Resource Index in detail and to look at all the categories that go into that in better detail than sort of the broader things like the Census of Governments allows us to kind of look at how that may really affect various racial disparities and ethnic disparities in a way that you can't really get if you're looking at broader categories. So that was really important to us in designing the CRI, that we looked at all the local budgets in minute detail so that we could categorize really specific programs as opposed to broader buckets. I know we just sort of jumped into talking about CRI. That's what we always love to talk about. I'm not sure if it's on the next slide, but I'd be happy to define it. But I don't want us to jump away if anyone else had anything to say about this.
Yeah, we'll jump into kind of a visualization of how you've used CRI. But I think it's really helpful to know that the census, structures the existing data that we have, albeit not necessarily data that is produced by any of the jails, prisons, or health organizations within jails and prisons. We kind of have to work with what we do have on a government federal level to start to pick apart this puzzle. And Leo, I know that you've, looked at a lot of different factors and starting to really digest like where to put attention first. And certainly drug possession arrests and kind of your framework of, the policing as a public health, like structural determinant of health. Tell us a little bit about how in the example of drug possession arrest, that kind of helps ease into this discussion of like how we can look at health disparities in this space.
Sure. So I think a lot of conversations around mass incarceration in the US touch on the role of the war on drugs, which probably has been evolving since the 1970s and actually even long before that. And there is kind of a debate about the role of the war on drugs as a driver of mass incarceration, because absolutely arrests for drug possession and other drug crimes do lead to a lot of criminal justice involvement, especially for Black and brown people. There's actually just a couple of days ago, yet another report that came out in California looking at the disproportionate number of police stops and arrests of folks of color for a variety of crimes, including drug crimes. So just to be clear, white folks and non-white folks engage in drug-related behavior and other kinds of illicit behavior at the same rates, but they're not arrested and charged for those crimes at the same rates. When we look at various stages of kind of the criminalization process, from arrest to arraignment to sentencing, there are major disparities in what people, on kind of the burden of criminal justice involvement, criminal legal involvement. And there are many, many reasons for that. But the result of that is that folks who end up behind bars are disproportionately people who are Black and brown. And when we look at the kind of the health effects of incarceration, as well as the reason why people are incarcerated. So specifically what I'm thinking about is, people who have substance use problems end up being incarcerated at higher rates. And then people who end up being incarcerated also end up developing substance use problems and mental health problems as a result of incarceration. So it's a little bit of a circular process. But the bottom line that I want to emphasize, and in our lab, in the action lab at Northeastern, we do focus on drug policy problems primarily. Substance use is a major driver of incarceration, whether it's people being arrested for drug-related crimes, including alcohol, or people who are engaged in other kinds of criminal behavior or criminalized behavior as a result of their substance use. And what that means is that folks who end up behind bars have substance use and behavioral health issues at much higher rates than the background population. So that means that addressing those health problems becomes even more acute within this population, and the need is higher, but the provision of services is really abysmal.
Yeah, and I think let's jump into kind of highlighting that. I think this graphic just really shows such a stark difference between sale and manufacture responsibilities and where that onus, lies versus the arrests for possession. So, another very striking PPI kind of graphic. Katie, or actually Emily, I wanted to jump to some of the work you've done. Again, Bureau of Justice statistics, like we don't have statistics from the actual, facilities themselves to start to tease out. And some of the data is available on a geographic scale, but teasing out which facilities, which contractors, which actors are responsible for kind of health outcomes is incredibly difficult. And so I see that your reference here in this graph is from the Bureau of Justice. So a little bit more aggregate data than I know that sometimes we'd like to be able to target on a micro level. But talk to us a little bit about what you found in, what we in the medical community, of course, have largely, have consensus around as a very effective treatment option for patients affected by opiate use disorder, and that would be the medication-assisted treatment, which, as we can see, is kind of, initiating that or continuing at falls to the bottom of the graph. But talk to us a little bit about kind of like what this means, and a little bit also about like what it means without the detail that we really seek from individual facilities, given that this is kind of on a national level.
Yeah, absolutely. So I think to start, I think the thing that stands out to me about medication-assisted treatment in jails and this data that we compiled this graphic from is that for a system that's so preoccupied with drugs entering prisons and jails, with drug-related crimes, with all of that kind of narrative around this, the system itself is actually doing very little to address that. I don't think that's a surprise to most people here. This just feels like another illustration of that. And so when we talk about jails and jail deaths and overdoses and things like that occurring at pretty high rates in local jails, I think that this kind of illustrates how that's happening. Even when we look at something sort of the most like urgent or emergent level of like treating withdrawal symptoms when somebody is entering the jail and immediately going into withdrawal, like only 50 only like half of jails are offering that. And so then as we sort of trickle down to some of the medication assisted treatment, you know, the reluctance to initiate people on treatment in jails is, I mean, there are some moments in which it makes some sense, right? Jail stays tend to be relatively short. But the flip side is that the referrals out to community-based treatment upon release from jails are also not happening, right? So not only are we seeing that like only 24% of jails are continuing medication-assisted treatment for people who began it outside of the jail, but the people who are starting it in the jail are also not really getting the continuance of care when they're released from the jail. So I think that's kind of what stands out about this. I also think that some of this is not as difficult to implement as the system kind of posits it. And I think that that's another thing that we can see here, right? That thinking about overdose education, right? Only 30% or whatever of jails are implementing that. And that seems like a relatively easy intervention. I don't think it necessarily, you know, rises to the same level as these other interventions. But yeah, I think that's kind of what I want to say about the graph. And then about the data, this is kind of a chronic, I see somebody put this in the chat, which is good because I wanted to bring it up. But something that's pretty problematic when you're looking at sort of the national perspective or the official narrative around what's happening behind bars is that the data is old. The data is always old. You can certainly get newer data from like individual facilities on different types of topics, whether it be population or the number of people using services that are offered at the facility and that kind of thing. But when we think about it on the national level, basically the best source that we tend to have is the Bureau of Justice Statistics, and it tends to be operating on a delay. Part of this is funding, staffing, all of that, but it's also kind of they have to get the surveys from all the facilities and then publish them. So I think that that's a really crucial point to make about this, is that this system, not only is it kind of like something we've put behind a wall or behind a curtain or whatever analogy I used before, but we also kind of like can't really get at it in current time. You know, we're always kind of looking back. So yes, I do hope that these numbers have improved sort of in the last few years. I also think that there is a chance that they didn't improve during COVID. I don't think that was a time where jails were particularly thoughtful about providing medication-assisted treatment or dealing with any kind of like opiate use or any substance use disorder. So I suspect, you know, it probably dropped and then maybe picked back up, but I still think, you know, 2019 is still years and years into what we've considered this opioid epidemic, and to see that this is still where we were then is relevant and is indicative of what happens in the system.
Yeah, absolutely. Go ahead.
I just wanted to add that I think these data are actually probably an overestimate in the sense that, you know, if a facility reports doing something, it might be doing that in a very limited way for a few patients. So for instance, oftentimes the only people who are getting medications for opioid use disorder behind bars are folks who are pregnant. And so a facility might be able to check the box, but only do it for, you know, a very small number of people. So there's a, you know, major difference between providing a service and providing it, you know, at scale and of high quality. And to you know, to Emily's earlier point, I think it's also the data from Bureau of Justice Statistics is extremely fragmented. There are thousands of law enforcement agencies throughout the United States. You know, very far from all of them report these data. And in many ways, the kind of obscure view of what happens behind bars is by design. We just don't know what's going on. And there's been, thanks to our colleagues at the U.S. Justice Department, like Greg Dorchek, there's been a number of lawsuits trying to force criminal justice agencies, especially jails, but also statewide prisons, to start providing medications to folks behind bars, medications for opioid use disorder, and change is accelerated, to Barry's point, but it's still at very, very low levels. And the fact that we're like 30 years into this crisis, and lots of folks with opioid use disorder do come into contact with the system, and we're still, sometimes in single digits, is criminal.
Yeah.
So add that it's also very possible that the kind of MAUD that people are receiving is not necessarily what they'd like to be receiving or what they were receiving prior to incarceration. So, obviously, if someone has to use methadone and they've been using Suboxone or vice versa, that really limits the agency they have and choices about their own healthcare. And it also may, limit how effective and safe it is for that person. So even if, the statistics say that there's a certain percentage of initiation or continuation, it really may not be what is best or preferred for that person.
Absolutely. So yeah, to the point about kind of this fractured system, the formularies of these different facilities can vary, immensely. And as Katie mentioned, MOUD, or medications for opioid use disorder, also referred to as medication assisted treatment, MAT, or medication for addiction treatment. Those are all kind of terms that you'll hear in this space as we kind of start to tease out like how to really get some policy on the table to advocate for the continuation and initiation of not only the treatment, but also the treatment that that patient has potentially been successful on in their goals for, ongoing therapy. I think that this idea of the fractured system and healthcare is, for those of us who've followed the ACA or, worked in health insurance or any of that, this is like not necessarily surprising that we have this incredibly fractured system of not only jails, prisons, but also the healthcare provided in jails and prisons. But I think that to Emily's point, the disappearance and the invisibility of a lot of this, the lack of transparency, is what makes the work here so difficult and very siloed, and statistics lagging behind and things like that. So I think that looking at something like the Carceral Resource Index, which I want to kind of flip to now, has been an incredibly imaginative and creative way to say, how do we target this space without getting the desperate access that we need to the real, like, on the ground data. And I just wanted to kind of hand it over to, Katie and Leo briefly to talk about how you guys, really creatively source the information to start with the Carceral Resource Index, what the main, kind of metric was that you were trying to really target. And then we'll go through a case example to kind of visualize how this plays out on a, city level, which, is arguably the most granular we can get from some of this Bureau of Justice Statistics data that keeps everything at this really high level, federal level. So I'll hand it over to you guys. Just talk a little bit about the index and the thought process behind it.
Sure. Just to set this scene a little bit before handing over to Katie, who's really our expert on this topic. The idea for the index really grew out of the national discourse that happened in the wake of the killing of George Floyd around defunding the police, and the kind of polarization that was happening around specifically police funding. It was just a very and continues to be very heated debate. People are very polarized about it, and I think it's probably safe to say at this point that it has, kind of calcified and not produced much productive policy change. But being researchers, I think for us, it was a debate that was oftentimes devoid of specifics. There were oftentimes numbers being thrown around, how much is the budget for police in this city versus this city. And there was not really a benchmark that was useful to assess, whether indeed, there was a problem with police funding, or, if police was overfunded. And so we started thinking about how do we put a little bit of an empirical lens on this very emotional debate, and came up with the idea that we would actually compare a broader set of funding priorities in the carceral space. So that's policing and courts and other systems of criminal legal control versus health and supportive services on the other. So we're basically creating kind of like a balancing metric of how a unit of government approaches its income, its spending priorities. So how, people say money talks. Okay, well, what does it look like for a specific jurisdiction in terms of how they prioritize their spending? And so Katie can talk more about how we went about compiling these data and what the data actually say.
Thank you so much, Leah. Yes, so what's fascinating, I think, about CRI is that because we download off the 150, 200 page budgets for all of the 212 major cities that we look at, we really get to spend a lot of time looking not only at the general fund, but what has been how they choose to delineate and categorize things. And what's difficult, as we were saying before, in terms of transparency with this kind of data, is that when you look at the sort of data that's aggregated, that comes from something like the census of local government data, you only get to see really broad categories. They split it up, I believe, in terms of housing and community development, parks and rec, hospital and health, public welfare, police, corrections, and judicial/legal, I think. And so those categories, while helpful for kind of seeing what the general trends are, there's two issues. How we define something as being, health or support, and what sort of falls broadly under the world of police and corrections and judicial and legal may not necessarily align with the broad standards in that data set. And also that data being released and aggregated usually is on a 3 to 4 year lag. So, right now what's available in aggregate is up until 2020. And so we can look at every year's published budget for each city once it's available, and download off that data and have it have better access to it sooner, and then also have more confidence in how that data is analyzed and collected. So in terms of how we sort of bucket out, there's 3 categories: health, support, and carceral. And of course, all of you likely very familiar with the definition of an index, but essentially the CRI score for every city can range anywhere between -1 and 1. And the closer that a city CRI score is to -1, as you can see in our basic index formula here, means that the city's spending prioritization falls closer to what falls in the carceral bucket than what falls in the combined health and support category. So things in the carceral bucket are, everything in the budget for a police department, investigation and accountability boards, sheriff's offices, forensics, courts, corrections, community supervision, parking citations, etc. So really broadly capturing everything from incarceration to community supervision. And then health and support are things like housing, neighborhood development, human and civil rights, boards of ethics, 311, housing, public health departments, health and human services, the VA, the list goes on. So we really broadly try to capture all of the spending that is going into affecting community and public health, as well as, surveying members of the community. So that is what goes into the CRI. And of course, as I mentioned, there's 2 key data sources. One is effectively a primary data collection where we are ourselves downloading off the fiscal budgets for 212 of the major US cities, and then manually coding through and delineating what falls into each of those buckets every year. And then we also have a data set specific to Massachusetts for the last few years for Massachusetts cities, letting you all know in case you're interested in seeing or accessing this data. And then of course, we do also take advantage of the aggregate data because it allows us to see as far back as 1977. And that has sort of helped define what kind of key trends we want to delve into. So those are the 3 categories that we have CRI calculated for. And that's what goes into it.
Yeah, I mean, the ER doctor inside of me is like, work with what you have is sometimes the best you can do, but like what a labor of love to have gone through, pages and pages and pages of budgetary details to really try to parse out kind of where to bucket these very large systems that we work in. But I think the results are incredibly striking. So I do want to show kind of the next slide, which Emily, I'm just curious. I know that like you haven't worked on this data set, but I'm gonna like put it up on the screen, and I just want to get your initial reactions kind of on a city level, and whether or not your feeling of like kind of coming into this index, how relatable these outcomes are. So just to kind of highlight, we have San Francisco kind of in that 0 to 1, Washington, DC, Boston, New York, Philadelphia, and then we have Virginia Beach and Seattle, and more weighting in the health and support space than the carceral space. Just like some initial reactions, and then Katie and Leo, I'll have you walk us through this and the next graph, which actually compares two specific cities, LA and San Francisco, side by side.
Sure. So I think the first thing that comes to mind is that this, I think that this makes sense. Like as looking at this, like you see that the trend is for places to be weighted more heavily towards the carceral system. And I think that tracks with like what we know. And this serves as further evidence and clear evidence that that's the case. And I think looking at the city level is pretty crucial because we're talking about, not to harp on the whole pie that we showed at the beginning too much, but these things are happening at so many different levels, right? And where we can impact the most change, where we can make sort of meaningful policy change that will affect individuals perhaps the quickest, perhaps the most directly, is going to be as local as you can get. I think that doesn't mean that there's no reason to like work at the federal level or the state level. I think those are really important, but I also think the city level, the county level, those are places that are really ripe for intervention. And I think this offers a tool to identify where those targets might be. Especially if you're, for instance, working in the state of Massachusetts and, Boston becomes a target where you can maybe move them a little further up the health and support, or maybe you want to choose like the more challenging cities and try to bring them up. But I think sort of that's from like an advocacy policy standpoint. I think from a data standpoint, this also serves as like support for what we've seen on a delayed scale, right? About how these systems within the carceral structure are expanding, even though we might be, seeing more information about like defunding the police. We're still seeing jails being built. We're still seeing new prisons being built. And we're still seeing cop cities being built. We're still seeing police departments expanding. Like all of these things are still happening, even while that narrative language was going on. And so how to kind of balance that on the data side, I think this offers a pretty good tool for. I think those were your questions, hopefully.
No, it's super helpful because I do think like coming from a place at PPI where you're thinking about macro and aggregates, just starting to see the details kind of come through in some of the city data is very striking, and I think very important to like continue to kind of make the narrative more granular and meaningful for what people are experiencing in our communities and on the ground. And I know for some of us, the practitioners like in the actual jails and prison space that we work. And so Leo and Katie, I just want to take a minute. There we go. To talk through just for a minute or two, kind of this breakdown, very striking difference. I did my residency in Los Angeles. I know there's some folks on the call here who've interacted with the Los Angeles County jail system. Very much a very important and critical moment to kind of reflect on this difference that we're already seeing in two cities in the same state, with very large and diverse budgets. But just talk us through kind of what you guys made of this very striking visual that the CRI was able to produce.
Sure. So something to keep in mind, again, to those of you who are familiar with the Sankey diagram. So all of the categories here are the same. So on the left, you'll see the carceral health and support total in Los Angeles in your far left category, and on the sort of the left of the light blue line in the center of LA. And then, you know, juxtapose that against the same general bucket categories on the left side for San Francisco. And so you can really see what it looks like when you have a city that overweights towards, you know, the -1 side of the CRI index with Los Angeles versus what a city budget sort of can look like when you move above that line in San Francisco. So what we were talking about before, where the majority of cities in CRI are below the 0 line, weighted towards the carceral buckets. And, you know, San Francisco is one of the very few cities that are above that line. And this is when we say that that's what those index scores look like. This is what that looks like operationally in terms of community support and services for people perhaps who live in these cities. So tangibly, what that difference in support looks like is the amount of funding that something like HHS or public health, Parks and Rec, housing, employment, arts and culture, et cetera, are receiving in these places, even within, you know, large cities in the same state.
And I think that it's important to note that obviously folks who live in these cities may be receiving services that are financed by other sources. You know, that's the complexity. There's a multi-layered funding structure to our services by city, county, state, federal, private. So it is a complicated picture, and this is only part of that picture. Having said that, why do we see so many cities prioritize carceral spending over health and supportive services combined? Right? So the index is health and supportive services in one bucket, carceral in the other, and we're still seeing more money spent on carceral systems than health and supportive services like housing combined. And I think that, you know, the kind of the positive message of the Carceral Resource Index is that we can actually try to using the empirical kind of numerical data, we can actually try to find the right cocktail, the right mix of funding for producing positive public health and public safety outcomes. And so far, what we found is that actually cities that have more carceral spending have worse health and public safety outcomes. And so that's something that we're working on producing. That's what Katie's PhD research is going to be focusing on.
Just a small endeavor, Katie, after the pages of budgetary evaluation. Well, I think one question just that I do want to tackle, because it came up in the chat as well, is how did you guys control for population differences between the different cities and kind of pieces of the pie?
Yes, that's a great question. Thank you in the chat. So what we presented here, obviously, you know, is not how we would, you know, assess any sort of causal difference between the two cities. We wanted to give people a good example of what two completely different weights look like in terms of split by each of the smaller categories. So when we talk about population size and how much is spent, that is part of the reason why we have multiple data sets, and we look at multiple years. So we look at all 212 of the most populated US cities, and that helps us have a large enough data set that we can sort of see what the CRI trend looks like in terms of city prioritization. And as Leo was saying, there are certainly cities where, you know, county departments of public health or, you know, sheriff's offices that cover a larger area may take over some, you know, a greater portion of those responsibilities in that place. So what CRI tries to do is serve less as, you know, a causal determination about whether or not a diversion or something like that in terms of amount of spending causes, you know, a causative shift in community health, but more as a lens for what specific budgetary items are being focused on in these places. And so having a large data set over multiple years and for so many cities helps adjust for that. But in any, of the modeling that we run, where, like we're doing now, looking at associations in Massachusetts and CRI spending and prioritization and overdose mortality, that's obviously weighted for population. But excellent point. The point of this graphic is just to show you how two cities can look very different. But absolutely, you'd want to weight by population size if you were, modeling for some sort of causative outcome.
Yeah, and I think it gives a peek under the hood to kind of the language of these budgets in thinking about next steps towards advocacy. Like, what is the language that, is captured in the city of San Francisco versus in Los Angeles, that then you can kind of, get to the more granular level of, well, how much are the sheriffs responsible for some community programming, and how is that titled? And maybe that's an area to target, or that's just budgetarily like wrapped up in a different way than it is in San Francisco. So I think it gives us a really important peek under the hood of like how diverse this, tackling the system is, and from how many different angles and how many different like methods of categorization exist. And we're talking about a transparent budget, that we have access to and can look at, let alone kind of the themes of, disappearance and invisibility that it makes accessing the care within jail and prison and outcomes within jail and prison so difficult to reach. So I think this is just like a really wonderful way to start to visualize where we could go. And before I open it up to Q&A from the audience, one question that I had, just reflecting at this point in each of your careers, a lot of us in the group here are bringing personal experiences of our loved ones, family, friends, expertise after years in this field, and a lot of energy and inspiration, curiosity to keep working in this space. What recommendations do you have for how to begin to tackle these issues, that you've been thinking about in the last couple of years of your work? Maybe Emily, I'll start with you.
Okay. I was getting ready to unmute. So I think, well, first, just to go back to this graphic that's up, I think that one of the really crucial things about this is that it gives you those targets, right? Like, it gives you the language to approach city governments, city agencies, right? And say, like, this is the amount we're spending on public health versus the sheriff or whatever it is, and I think that's what a lot of like grassroots local organizers are trying to do, is find those targets. So I think that this also offers that, even as like a side effect of the actual CRI. So I think that's really cool. So then the thing that I think about in sort of this space and like making change is that sort of two things, I guess I want to say. The first is that there is always this drive and this push for more data and more information. And I do think that's important. And that is most of my job. But I also think the flip side of that is that we already know that this system is not working, or it is working as it is intended to, which is not how it needs to work. And so I think that there is evidence that we can make changes. And so I think there is sort of the possibility that as a movement and as people who care about this work, we can get a little stuck in the like, what does the data show? And I think what CRI and this like graphic in particular show is that there's like actionable items that we can take already, and that we don't need necessarily 2024 data on how many jails are offering medication assisted treatment to say we need to make changes and to start making those changes. So I think that's one of those things that I just think sort of globally in this movement can be kind of tricky, right? There's a drive to prove your point, and also there's a point at which the point has been proven, and we need to kind of take action. And so I think it's encouraging that people coming into this space, with lived experience, with experience of family members and loved ones, or working in facilities like that drives us more towards this action than towards this like remove data collection stance. And I think that's perfect. I also think that this space is really this criminal legal system reform health Venn diagram of things is really in need of sort of this personal experience side of things. And so I think that folks bringing in experience, whether it's something like having worked in the healthcare system and moving towards advocacy in the criminal legal system, whether it's having worked in a jail as a physician and, taking that to whatever your next career step. I think that those lived experiences are so, so crucial to this moment because of that like curtain/wall, because it's so hard to like get behind that and see what's happening. When people can step out of that space and bring what they know and what they've experienced, that's like, I don't know. I think that that's a huge part of this work. I think I said I had a second idea, but I forgot it. So
Yeah, wonderful. Thank you. And Katie or Leo, any reflections?
I guess I think one frame that I would offer is, we do a lot of work, and pretty much throughout my career, I've done a lot of work on harm reduction. And harm reduction is, a set of practices and programs focusing on kind of a realist view, and the motto is meeting people where they're at and trying to make positive change rather than setting off in a kind of a magical thinking. And I think that applies to people, but it also can apply to systems. So I think it's important to meet the world where it is and kind of understand where it is and try to move it in a positive direction. And I think that's what we try to do with the CRI is, think realistically about just demonstrating how out of whack the system currently is, and thinking about making positive change where, it may be incremental, but it's important to kind of make that goal rather than a goal of, sort of magically transforming a system, to think about what incremental change, positive change can look like. And that's, the CRI, like if we are able to move places, at least in the kind of the, all of those cities that are currently in the negative category, if we can make them at least neutral, if we can at least balance expenses and priorities between health and supportive services on the one hand and carceral resources on the other, we will have made a major change. And that's just a goal setting that I think makes it a little bit less daunting.
Leo's point about incremental change, I think is absolutely something to focus on, and is very fulfilling in this realm. I think if you focus on the sort of methods, whether it's practicing clinically or data analysis or data visualization or social media or op-ed writing, whatever the form of method for your brand of advocacy in this space is that fulfills you and brings you joy and that you feel really passionate about. I think that can help really sustain working on these kind of difficult questions, is focusing on methods that you also operationally enjoy, and that there are plenty of topics and areas in need of advocacy in this space, and that there's a world of wealth to be gained from having people with lived experience, and we will all forever be in debt to people that make that service and work on things that they've personally experienced. But there's also lots and lots of other areas of advocacy, and there's nothing wrong if something's too close to home to work on other areas in the space too.
Absolutely. Thank you all so much. And Katie, I'll hand it over to you to take a couple questions from our audience. And I'm just really grateful for the reflections on kind of what, can be very much be parallel to this diagnosis of like whole person treatment, and that the incarceration itself becomes something that lives with a person, impacts family, friends, health outcomes, et cetera, but really needs to be tackled as a whole entity. So yeah, let's take a couple questions. I think we have a few minutes from the chat.
Yeah, we've got about 10 minutes left. And so we've got a question from George Hutchins. George, would you like to unmute and ask your question?
Yeah, sure I can. First, thanks to the organizers and thanks to the panelists for sharing, and shout out to Kara, of course, as always. My question, I'll be brief. So I'm just wondering how we might think about these carceral spending trends in the diagram in relation to the strength or activity of police unions in certain cities. I imagine some unions are probably more active in making sure that funding is allocated to policing sources as opposed to, other public health sources. And thinking about that in relation to those that on the public health space are advocating for more funding. So I'm just curious, is there a relationship and how we might think about that?
2 points to that. That's an excellent point. And one of the key goals of the CRI is continuing to clean and make the data open source on our website, and to have the data sets eventually be downloadable publicly. And so that is an excellent question and is not a variable that we've operationalized by. But the beauty of the CRI is that the data is well organized enough that you could just get a data set or calculate just variables about police union activity and then be able to look at that against the CRI. That's definitely a great point and is something that we'll consider. And then the second point to that, to your hypothesis, is that for the data that we do have for the CRI from 1977 to 2020, you see that the median CRI across all 212 cities that are tracked has trended further and further towards -1, almost linearly. And I think that does speak to the sort of general trends in that sort of, obviously a myriad of factors, but that likely contributes to the fact that we've seen an increase in pushing in that direction. But yes, the data will be open source soon, and we invite questions like that, among many others, to consider against the CRI. Thank you for that suggestion.
Vera had a question. Vera, would you like to unmute and ask your question? Vera Crum. If not, I'm happy to ask it for you. But go ahead.
Oh, I was speaking of the PLRA. I think they're the major problem as to why prisons are the way they are now. Can't get anything done. You got prisoners going around, some of them dying from the not getting medical care. Others, just like my son, is critically injured due to their negligence, not taking care of the problem when they knew about it, but they just gaslighted him so bad that now he's in a wheelchair. Bad medical. North Carolina is just horrible. I've tried to get help for him, but they're not listening. They don't care. And it's just awful that they had to let him suffer like this, even though they knew how to fix his problem, but they chose not to. And that's the major reason why I tune in today.
Thank you for that testimonial, Vera. It sounds like part of what you're looking for is kind of figuring out advocacy resources. Is that right? And thinking about how, one, to get your loved one access to medical care, but also to what extent there's the lack of accountability in the system. You mentioned the PLRA, right, which is the Prison Litigation Reform Act, for folks who don't know that acronym, right, which creates, I think, really high bars for people who incur what we might term medical neglect or any other number of issues, including direct abuse, excessive use of force, whatever, in when they're incarcerated, right? I don't know if our panel has thoughts about that, about whether litigation strategies might become tools of accountability. Maybe Leo can give us some insight on that.
Yeah, Vera, thank you for sharing your experience, and very sorry to hear about your son's condition, which unfortunately is more the norm than the exception, in the sense that the system is so broken that it harms a lot of folks. It's supposed to be helping. The system of rehabilitation does nothing of the sort for most folks. And the paradox is that the system that is supposed to hold people accountable and upholding the law is not itself accountable, or follows the law very rarely. So that is yeah, just one of the many paradoxes of the system. Now, there are many barriers, and this is part of that accountability issue, to holding these systems. And, it's almost impossible to call it the criminal legal, system, because there are like thousands of fiefdoms, and all of the different barriers that are put up to holding those institutions accountable make it, yeah, just almost impossible. Now, there are some bright spots in that overall, pretty bleak picture, and that includes more recent efforts by, I mentioned, the Department of Justice is taking a much more active role in upholding healthcare standards behind bars, including for medications for opioid use disorder, but not just that. And this is, I think, is really important to note. I think the conversation around the toxic role of law enforcement as killing and injuring lots of folks is a fair critique, of course. But the flip side is that there's very little law enforcement in many areas of our society, including upholding, basic standards within correctional institutions, but not just that. You can look at environmental enforcement and many other areas of law enforcement are just severely lacking. And so as we spend so many resources on law enforcement that does not actually produce public safety outcomes, I think it's important to note that those resources could be better spent on other kinds of law enforcement that would produce public safety outcomes.
Thank you for sharing that. I also just wanted to add in that sort of overall there's a lack of oversight of these systems, right? And somebody put in the chat, which was what I was thinking again, is talking about the Section 1115 waivers for Medicaid. So this is sort of an ongoing thing where the Centers for Medicaid and Medicare have opened up the opportunity for states to apply for additional sort of like testing funding for different kinds of coverage, and some of this is covering pre-release services. And I know that's coming later, but I would also just say that that is another avenue for oversight of these systems. And certainly Medicaid is not perfect and Medicare is not perfect, but there is sort of a system in place that if we could bring that oversight into these facilities, that would give some standards of care, that would give some expectation of accountability for the healthcare. So like along with sort of the litigation route, there's also this like expansion of Medicaid.
Yeah, absolutely. And I think kind of, throughout the course of the series, one thing that we'll really try to make an effort to do is include the multidisciplinary voices that it's going to take to really wrangle in this, as you mentioned, not really a system from what it feels like at times, but all of the key stakeholders and players that we can think of to really, creatively approach some of these issues from maybe a regulatory standpoint, as mentioned, from the legal standpoint, maybe litigation standpoint, and really thinking about kind of novel and innovative ways to get creative in this space, and call upon the community of folks that are engaged in this. Just like, when you're diagnosed with something, you need a whole village of people to kind of support, including specialists and generalists, and second and third opinions at times. So I think, we're hoping to really kind of keep that in mind as we move throughout the series. And we'd love to hear from you all about kind of your thoughts on voices that we can get connected, so that we can start building towards community and innovative, creative solutions together. So I just wanted to thank everyone so much for being here. To our speakers, our illustrious speakers, whose work we've admired for a long time, Emily and Katie and Leo. I really can't tell you how grateful we are to really learn from your models, and the work that you've chosen to share from, from the perspectives that you have of data analysts and just folks who've done the lived experience of working in the healthcare space as well. Thank you, and we're all very grateful. So we'll go ahead and close the session for today. Katie, any final words?
No, just that, again, we're back next week on the 25th of September. Our next event title is Health Checkup, Current Medical Standards of Care in Jails and Prisons and Detention Centers. Again, you are all invited back, and thank you very, very much to our speakers today. We really appreciate you sharing your expertise with us.